So, adherence is such a challenge because I think many of us don't even realize that all our patients aren't really taking all the medications we prescribe. We saw even when we would just give hormonal therapy by itself, about 25% of patients aren't even taking their medications. So it's striking, and I think you're never going to know unless you ask. And so I think Lindsay and I have made it a point with all our visits to not only ask what side effects are they experiencing, but are they actually taking their drug, and how many times did they miss taking their drug, and why did they miss taking their drug? Was it, sometimes it's because of a side effect that they really just can't bear the thought of taking a drug that's causing them side effects. Sometimes it's financial reasons. Sometimes the copayment's just too high and they didn't pick up their last prescription. But again, you're not going to know unless you don't ask. And so we've, again, made it part of the routine visit is, how many times have you missed taking your drug this past month or whenever it's been, just so we get a sense of what's going on, and then see if we can fix it and to find out what the reason is so that we can help improve that.
I feel anecdotally, though with these drugs, it seems less than with other drugs. So with people taking their supportive medications, they're often very erratic with that. But this is a new level beyond just endocrine therapy for them, and they feel that they really need to take it because they're worried about their cancer having recently progressed. So I hear less about adherence with these than I would say about some other drugs that they've been prescribed. There's a team at our institute that is required to call patients who start any oral anti-neoplastic agents. So that's built in, and usually the program nurses that we have are in touch with them anyway about procuring the drug. So if anything, I get sometimes reports that they're having too many phone calls. But yeah, so it's rare that they're not hearing from one or more people.
I think the class CDK4/6 inhibitors has really revolutionized the way we treat patients with metastatic hormone receptor positive disease. I think it's so unique that these agents are able to control disease for twice as long as endocrine therapy would have, that now we see a survival benefit in the second-line setting, and that generally they're pretty well tolerated agents. It allows patients to get oral drugs. They're not coming into clinic as much as they would be with IV chemotherapies, and yet they're also able to cause significant objective responses. We typically think of endocrine therapy as not causing, significant reduction in tumor volume, but that isn't the case with CDK4/6 inhibitors added to endocrine treatment, where the first-line response rate is as high as 50%. And so I think it also allows us to see patients in clinic, and even though they may have significant visceral involvement, we're able to give them endocrine therapy with a CDK4/6 inhibitor, whereas 10 years ago these are patients that would have been getting chemotherapy in the first-line setting. So it's completely changed the way we practice. And again, it's so hopeful to see that it's also improving their long-term outcomes. So I really do feel like it is standard of care to give a CDK4/6 inhibitor with endocrine therapy, whether it be in the first or second line setting.